So, three keys to a more accurate patient history. Let's jump in. Why is this a big deal? And what is the problem at the initial exam that we really need to cover? According to research, most patients have an overwhelming amount of patient anxiety. In fact, 30%, it's estimated that 30% of patients don't pursue medical care simply because they're worried about what we'll find. 30% of people don't go to the dentist because they're worried that they have cavities. 30% of people don't go to cardiologist. Why? Because they think that the cardiologist will confirm they have a problem. 30% of people are not getting care because of anxiety about what's going on. What about everybody else? Well, if 30% have so much anxiety that they're not even showing up, we can assume that a large part of the people that are showing up have a lot of anxiety as well. Not enough to prevent them from coming in, but in fact, a lot that prevents them from being totally honest with you as a provider. Maybe it prevents them from answering questions honestly. And the problem that develops is we as providers take the patient history to be 100% accurate, when in fact, research currently says it's maybe 50% accurate. How do we change that? How do we guarantee accurate information? One of the other problems is patients are very nervous to ask questions, much more than you think. Again, looking at the research, so many patients are nervous to ask the doctor a question. Some of this is cultural. Some patients believe that the doctor is never wrong and therefore should be held at a very high standard and don't question them ever. Sometimes there's language barriers, there's cultural barriers, there could be age barriers, an older doctor with a young patient or vice versa. There are many, many barriers that may limit patients from feeling like they can ask questions. The core issue there is that questions often lead to the best discussions that reveal the true diagnosis that's going on. Only when people ask, is it a big deal if my right foot is numb? Or is it a big deal if I can't control my bowel or bladder function? Is it a big deal I pee my pants when I exercise? Those kind of questions we obviously want to open up to as providers. But on the same regard, if we don't pave the way for those questions, they often won't happen. The initial exam or initial history will be cut short with just yes or no questions, and we won't really have a true picture of what's going on. So patients are often worried to ask questions. Also, in the research, it often happens that providers lack empathy. Now, I don't think that there's any provider out there that wants to lack empathy. I think when the research says this, what we're dealing with is all of this care and all of these histories are being done by human beings that have their own concerns, human beings who might be feeling a little sick or worn down or tired at the end of the day, and they're not displaying the empathy that gets that patient to open up. What if a patient found out that their child is sick or that someone in their family died recently? We can't ensure that they'll ask the right questions or that they'll display that empathy that gets patients to open up. How do you combat that? We'll talk about it in this webinar, but the easiest way is send messages that are automated that guarantee you don't need to be a hero that day. If the messaging and the content of that message is correct, you can ask it on your worst day and still appear as if you have empathy. Another subject brought up in a lot of the research about initial exams is providers lack humility. Even when they don't necessarily think they're being egotistical, patients perceive them to be that way. In fact, there's a study that I love that talks about the patient satisfaction leaving the initial visit. The providers, when rating themselves to an independent third party who also got to see the visit, providers often rank themselves about 80% effective, 87% effective, B plus, A minus. They'll say, oh yeah, I have a little bit to work on, but it went pretty good. So providers grade themselves 87% effective. If you ask the same patients that they just got done talking to at the same visit on the same day, those patients will rank them about 60% effective. So a full third difference that the doctors think they're doing a great job and the patients are thinking they're doing an okay or even a poor job of asking the right questions and following through. Why is that? Well, the provider is the smartest person in the room, essentially, right? They've spent a lot of time studying and learning for that moment. And in such, they understand the problem that they're being faced with or the patient is facing much better than the patient themselves do. But It's the patient's first time. You may have seen 1,000 patients in your career, 5,000 patients, 10,000 patients in your career. But to that patient sitting in front of you, this may be their very first visit about this condition. We need to be humble to get them to open up. And humility leads to empathy and trust. And that's really what we're all about. Another issue that's brought up often in the research is that the physical healthscape can be challenging. If you do an initial evaluation where you sit across the table from your patients, they're not going to be as honest, and they will have more of that anxiety. However, if you can just change things very simply by sitting next to your patient or sitting in an L formation, two ends of the L, they seem to open up better. But that physical healthscape may be challenging, especially if you're not the one who has the control over how to set up that office. So it's worth addressing, but moving chairs around and sitting across from your patient can help quite a bit, or sitting like kitty corner from your patient can help quite a bit. Finally, there's often language barriers and belief barriers. Some patients don't believe that doctors can help, or they believe that they have bad spirits that are causing them to be ill. I've talked to a chiropractor who says that they work with a lot of Hispanic patients, and then there's I don't remember how it is, but there's a spiritual demon essentially that can cause low back pain, and perhaps they feel like they believe that, but when they share that with the doctor often scoffs or laughs at it, creating more and more barriers. Even though they may have a different perspective, we need to honor that and validate them and not laugh or scoff at them. It's made even worse when there are language barriers, because now the questions we may not get the right answer to, or asking somebody who speaks Spanish, porque versus para que, may get you two different answers, even though in English those translate to nearly the same thing. For what reason, right? So it's important to overcome those language barriers. Again, that's easy to do with technology, because you can set technology up to be delivered in the language of the patient.